I'm going to explain the tips and pitfalls in dye injection in VAL MAP. Dye injection is the key in the success of VAL MAP. However, the technique of dye injection is somewhat subjective, and there needs objective technical indicators to achieve clear marking with less complications. Appropriate dye injection in VAL MAP is somewhere between too weak injection and too strong injection. Too weak injection results in about 10% of failed marking that is not visible during operation, while too strong injection leads to pleural damage, bulla formation, and pneumothorax. This is a grading system of marking, basically reflecting the strength of dye injection. This grading is useful to know how appropriate your technique is, and you can feed it back to the next chance of VAL MAP. So, how should dye be injected? I'm going to show you the ideal technique of injection. Firstly, the catheter is wedged at the very periphery of the lung. You must watch the fluoroscope. At that moment, you cannot push the plunge of the syringe. Then you withdraw the catheter just a little bit, 1 to 2 millimeters. Still, you cannot push it. However, at some point, you reach the point where you can push the plunger. Then you progress the catheter slightly while pushing the syringe. Then the peripheral airway is opened a little bit, and then the dye comes down to the visceral pleura. And finally, the pleura is stained, that is visible during operation. This is a replay. At some point, the tip of the catheter is now unwedged. Extra air escapes beside the catheter. Push the catheter a little bit. Then that dilates the peripheral airway. Then dye comes down. The pleura is stained. Sometimes in the middle of injection, you might hit a point where you cannot push the plunger anymore. What's happening? This happens because when you progress the catheter while you push the plunger of the syringe, the catheter tip gets re-wedged. In this case, you can just slightly withdraw the catheter again to the point where you push the plunger without too much resistance. It is important not to withdraw the catheter too much. If you cannot push, then you pull. This is the principle. This should be done just gradually and slowly though. Now I explain technical pitfalls that results in invisible marking. Markings that are invisible during operation is graded as grade 0, and slightly visible markings are grade 1. They are too weak markings. If a marking is not well visible during operation, this is mostly due to what we call a central injection. So this CT scan shows a visible marking during operation. So GGO is expanding into the visceral pleura. Now, this marking was invisible during operation. You can see GGO, but this is a little bit away from the pleura. This is the intraoperative finding of the same case. You cannot find the marking that didn't reach the pleura, but you can easily find it if the marking reached the pleura. Here I show another case. So this is a marking that reached the visceral pleura, the fissure between middle and lower lobe that was visible during operation clearly. On the other hand, this marking was made away from the visceral pleura, and that was not visible during operation. This is intraoperative findings. If you cannot find it, you cannot find. So, based on localization of other markings, we estimated the marking that was supposed to be there. That's fine, but of course it's not ideal. When does this kind of central injection happens? One of the reasons is no wedge central injection or dye injection without wedging the catheter from the beginning. If you progress the catheter and push the plunger of the syringe without wedging it, of course the dye will be injected in the relatively central airway without reaching the visceral pleura. then the dye won't be visible during operation. When does the no wedge central injection happen? One of the mechanisms is insufficient experience or no care in terms of the feeling of hitting the pleura. The feeling is just like TBLB. Second, not seeing the tip of the catheter on fluoroscopic monitor. So how can we prevent such no wedge central injection? One important thing is to use rotation of the fluoroscope or change the patient's position, especially in the dorsal part of the marking. And also it's important to watch the tip of the catheter carefully on fluoroscope, especially if the marking is made in the interlobar fissure or somewhere that is not visible in fluoroscope. Now I explain another important mechanism of central injection, that is excessive withdrawal. I'm going to show you how the excessive withdrawal happens. So firstly, the tip of the catheter is wedged in a regular way. It's important to watch the fluoro monitor as well. And then of course you cannot push the plunger of the syringe, then you withdraw the catheter little by little. That is fine. Then at some point the resistance goes down and you can push the plunger, but if the withdrawal speed is too fast, then you withdraw the catheter too much and push the plunger there, then the dye is injected in the relatively central airway. When does the central injection due to excessive withdrawal happen? Firstly, too fast manipulation of the catheter after the first wedging. So declined resistance is better felt with slow withdrawal. And also, distance of withdrawal at once may be too much. Another reason is not watching the catheter tip on fluoroscope carefully, and you might also miss the movement of the dye on the catheter. This is something I need to explain a little bit more. So dye movement in the catheter is often a more sensitive indicator of unwedging of the catheter tip than the decline in the resistance of the plunger. So what I recommend is firstly watch the fluoro screen carefully to see the catheter tip movement, and then now focus on the catheter in your hand, then push the plunger to see if the dye moves. You repeat it until the dye moves. So how can we prevent the central injection due to excessive withdrawal? First important thing is after wedging, just slowly withdraw the catheter. Recommendation is just 1 to 2 mm at once. There's no rush. And secondly, as I just mentioned, I recommend watching fluoro first and then watch the dye movement in the catheter. Thirdly, if the tip of the catheter is more than 1 centimeter away from the pleura on the fluoroscope, probably you should repeat from the very beginning. Once again, it's very important to manipulate the catheter gradually, gently, and slowly. However, once the catheter is unwedged and plunger is pushable, it is important to complete injection with some speed, generally in 4 to 5 seconds with 10 mm syringe. Too slow injection results in weak marking. Dye is not sprayed on the pleura very well. Let me summarize the tips of good marking so far. First, move catheter very slowly. Second, watch fluoro screen very carefully. Once you get accustomed to the procedure, your movement of the catheter gets faster. That's a pitfall. And thirdly, dye injection itself needs some speed. Let's move on to the too strong dye injection that may cause bulla formation and pneumothorax. In the grading system, grade 4 target-like staining and grade 5 bulla formation are considered to be too strong staining. This is a CT scan of pneumothorax that was detected in post-VAL MAP CT. We experienced 4 cases of pneumothorax out of 100. None of them needed further treatment. This CT scan shows the bulla formation in which the catheter appears to have crawled beneath the pleura. In the movie, I'm showing a case of multiple bulla formation in which a technical problem, particularly too much pressure, has caused this problem. When does this pleural damage happen? One of the causes is excessive catheter insertion from the beginning. When you insert the catheter, you need to wedge it. But if you do it too much, catheter crawls underneath the pleura, causing pneumothorax or bulla formation. So when does this excessive insertion happen? First reason is insufficient experience or no care on the feeling of hitting the pleura. Once again, this is just like TBLB. Second, you may not be watching the fluoroscope screen when inserting the catheter, or you may not be recognizing the danger of inserting the catheter too much. Thirdly, rough manipulation of the catheter. It's always dangerous. How can we prevent pleural damage due to excessive catheter insertion? Catheter should be progressed slowly and gently while watching fluoro screen carefully. If the catheter tip appears bent on the fluoro screen, you should not push it anymore. That's very dangerous. Here is shown the second mechanism of pleural damage, that is forceful dye injection. So here's the animation again. First wedge the catheter and then withdraw it little by little, and at some point you can push the plunger of the syringe. At that moment you push the catheter a little bit, but if you do it too much against a high pressure, then of course that could cause the damage on the pleura as shown in the picture. When does pleural damage secondary to forceful dye injection happen? First is too aggressive catheter progression when the plunger resistance declines. In this case, catheter itself may cause the pleural damage directly. Second is too forceful pushing of the syringe plunger. Of course, there is a resistance push to the plunger, but if it's too much, the injected air may damage the pleura. So, how can we prevent this forceful dye injection? Firstly, when catheter is unwedged and catheter is progressed, you should do it slowly and gently. Second is what I call a communication with the pleura. So you can feel the resistance through the catheter and plunger of the syringe while injecting the dye. Lastly, let me summarize the tips for better dye injection in VAL MAP. Firstly, the procedure itself is more or less subjective, depending on sensation. So, feeding back the intraoperative finding or grading to the next chance of mapping is important. Secondly, the maneuver should always be slow and gentle. It's important to communicate with the pleura through the catheter and syringe. Thank you very much for your attention. By making full use of this instruction video, I hope you achieve good mapping and following good operation for your patient.